Good morning, everyone, and happy Friday. Welcome to today's session of Changing the Way We Work, Community of Practice for Ontario Family Physicians. I'm Eleanor College. I'm a family physician. I work in East Toronto. I'm also the CPD Program Director at the Department of Family and Community Medicine. Really delighted today to be able to bring you another session today on infectious disease and the HPV cervical screening implementation. And I'd like to turn it over now to our OCFP president, Dr. Jobin Varghese, to introduce the session.
Thanks so much. And this session is an exciting one. We are excited to have the infectious disease portion by Daniel Wachowski, as well as HPV cervical screening implementation. Just a quick reminder that the Cert Plus platform continues to have a little bit of delay due to some set changes, but this is a 1 credit per hour main pro credit. Can we go next slide? Just a quick land acknowledgement, and then I'll turn it back to Eleanor. We acknowledge that the lands on which we are hosting this meeting included traditional territories of many nations. The OCFP and DFCM recognizes the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects the Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Thank you and welcome. And Eleanor, back to you.
Thanks, Jobin. And I'm calling in from Toronto, the lands traditionally used by the Wendat, Anishinaabe, Haudenosaunee, Chippewa, and Mississaugas of the Credit. And I thought I wanted to reflect today on an Indigenous concept that was initially developed by the teachings of Mi'kmaq elder and chief Charles Labrador of Acadia First Nation. And then it was applied for the first time in the Western setting by the gentleman that you see on this slide here, another Mi'kmaq elder by the name of Albert Marshall. And this is something called Etwaptamunk, or more easily pronounced by me, two-eyed seeing. It was initially brought forward actually as part of a grassroots program to try and encourage Indigenous youth in Nova Scotia to pursue secondary education in science, recognizing that the current approaches that focused only on Western science were not engaging, and nor were they respecting or reflecting the knowledge and understanding that the youth brought forward from their own cultures. And since then, it's been used to inform policies and programs, especially those in areas such as natural resource strategies. And I'm certainly no expert on it, but my understanding is that it refers to learning to see from one eye with the strength of Indigenous knowledge and ways of knowing, and to see from the other eye with the strength of Western knowledge and ways of knowing. And then learning to use both these eyes together so that you can bring the strengths in each together in a way that you can move forward that's beneficial for all. Two-eyed seeing, or this gift of multiple perspectives, is something that's treasured by many Indigenous peoples, and I think something that we can all learn from. For example, when we're dealing with our own patients in the practice that are Indigenous, and also, I guess for that matter, any patients that are coming from backgrounds that are different from our own. And then I was also thinking about it from the perspective of our current world, which in many circumstances seems to be quite divided or polarized, and how important it is that we recognize that we respectfully listen and learn from each other, even if we have our differences. I wanted to finish with some guidance that also came from the Chief Charles Labrador of Acadia. Apparently, he said this frequently in his life, privately and publicly. And the quote is, "Go into the forest, you see the birch, maple, pine, look underground, and all those trees are holding hands. We as people have to do the same." Thanks. Next slide. Okay, so just a reminder that this session is part of a series. Always a big thank you to our planning committee, and we don't have any disclosures of financial support. Next slide, please. We have three panelists joining us today, Dr. Wachowski, Dr. Eisenberg, and Dr. Kupets. Next slide, please. And I'll turn things over now for our speaker disclosures. Dr. Wachowski?
Hi, good morning, everybody. Daniel Wachowski. I'm one of the Associate Chief Medical Officers of Health in Ontario, and nothing to disclose.
Hi there, Dr. Jonathan Eisenberg, Provincial Primary Care Lead of Cancer Screening at Ontario Health. I have nothing to disclose.
Okay, hi everyone. My name is Rachel Kupets. I also have nothing to disclose, and I'm the scientific lead for the Ontario Cervical Cancer Screening Program, as well as a gynecologic oncologist at Sunnybrook Hospital. looking forward to chatting with you today.
Thanks, Rachel. And next slide, please. Jobin?
Hi, everybody. Joven Miraguez, Ontario College of Family Physicians President. I also have a role as the Interim Assistant Dean of Primary Care Education at TMU School of Medicine and Associate Vice President of Academics at William Ulster Health System. Thanks.
Thanks, Jobin. And I've already introduced myself. I get an honoraria from the OCFP, and other than that, do some work with the Foundation for Medical Practice of Education, none of which poses a conflict for today. Next slide, please. So just a reminder for any of you that are new to our sessions, if you want to participate, we really welcome your questions. Please pop them in the Q&A section. If you see a question that you're interested in, please do upvote it, then I can know which ones to prioritize. And then for the chat, we encourage you to share your resources, your comments, say hello to your colleagues, and yeah, just network with them. So that's for Q&A and chat, those how you use it. Next slide, please. Okay, I think in terms of just the session today, we're going to start with Dan and have an ID update, and then we'll break for questions, and then we'll follow that up with the HPV presentation by Dr. Eisenberg and Dr. Kupets, and then we'll have some questions. My aim is to be finished all the main content by 9 a.m. If we need to go over for some additional questions, we'll go until 9:15. And we'll go to the next slide, please, and get started with Dan.
Great, thanks so much, Eleanor. And don't worry, everybody, I'll be fast. The HPV stuff is more exciting, we all know. So just a quick update on the respiratory season so far. So this is, showing us our big three in terms of COVID, RSV, and flu. So COVID, as you can see, was a fairly moderate season this year, which is quite nice. Compared to other ones, it's also still not clearly seasonal as compared to our other ones, where you can see those very clear peaks in RSV and flu, and COVID just bumps around a bit. But overall, moderate season for COVID, and certainly we're well on our way down now at this point in the season. RSV, we had a pretty significant year, but I'll show in the next slide where that's been driven primarily by older adults as opposed to younger children as previously. So that's something to see, but it was a much later start than previous seasons and a fairly significant peak, particularly for the older adults. But again, we're well on our way down for RSV at this point. Flu was a very big flu year and drove a lot of our season. We're still quite high in terms of flu activity overall, even though we are now into March. Certainly, we are coming down from the peak, and we're well on to the decrease at this point. But we're still higher than even last year peak, essentially at this point in time, with the number of cases of flu we're still having. So a lot of flu activity still circulating in Ontario, which I know, just anecdotally speaking with colleagues, everybody's been seeing in their practice as well. So I'm sure that's not too surprising for anyone on the call. If we go to the next slide, please. So this is that same information, but now broken down, basically separating out our older adults over 65 from pediatric populations, so under age 5. And so you can see for COVID, it's obviously driven primarily by older adults. We have very, very few pediatric cases. Flu, there is a bit of a difference. Obviously, older adults are driving quite a bit, but you can see that increase in pediatric cases as well. And again, it's been a quite significant flu season, including among pediatrics. So we are still seeing that increase. RSV is where we see the biggest difference. And so you can see that the seniors this year was, first of all, much steeper and higher incline to getting to that peak. We are well on our way down, but extremely high season, especially when comparing to previous seasons for older adults. So RSV for seniors this year drove a lot of hospitalization, whereas for pediatrics, you can see it was even lower than last year. And quite a little bit of a drawn out season as well the later start. So obviously it's a little early. We think that part of the reason the pediatric season went so well for RSV for kids was the introduction of the Beyfortus program and Abrysvo availability for pregnant individuals. And again, a huge thanks to everybody for participation in that. But I think it shows that we've had some pretty good effect from having that new RSV program as well. For older adults, the other point to make, and I don't have a slide here on that one, is just we did see fewer RSV outbreaks in long-term care homes and retirement homes this year than last season, despite that really high level of cases in the older adult population. Those are, of course, the populations primarily where we have the RSV vaccine for older adults being administered. So it looks like our RSV products are really helping us out at this point. Next slide. We're starting to get some initial data just on the effectiveness of our vaccines for this year. So this is coming from the CDC, from their reports. So you can see here for flu, we had pretty good year in terms of effectiveness. So you can see for children, adolescents, quite high, up to 78% in some centers against any hospitalization, which is very, very good for a flu season. But against outpatients, probably there's that one lower one at 32%, but 59 to 60% against outpatient visits. A little bit lower for adults always than kids, but still quite good, probably in that 45 to 55% range against both outpatient and inpatient visits. So really good year for our flu effectiveness. For COVID, about 33% effective against emergency department, urgent care visits, and this is all in adults for the COVID effectiveness. Better again against hospitalization, which is what we know. So in that 45 to 46% range and about 40% for immunocompromised. So a little bit lower for COVID this year than we've seen in some previous seasons. And hopefully next season we get a bit of a better effectiveness from that one as well. Next slide. I wanted to give a quick update. PHO just recently published their epidemiology report on what we're seeing for measles in Ontario at this point. And we're having a very, very significant year for measles. And that's even taking last year into account when we had that increase in both travel-related cases and outbreak-related cases. You can see here, so this is going back to late last year. Essentially, we have a large number of cases that are related to a specific outbreak in southwestern Ontario among unimmunized populations. At this point in time, I think as of this PHO report, we were about 178 cases related to that outbreak. So really quite significant. And this is, the highest number of measles cases we've had in more than probably 2 decades in Ontario. So it is quite significant and it is ongoing. So you can see that most recent week here was the largest increase in cases that we had over the time for this outbreak. Next slide, please. Just to show again this one. So again, the vast majority of cases have been unimmunized. So again, this is predominantly among the populations that choose not to immunize their children. The cases that we've seen have been immunized are kind of individual cases that have been contacts outside. And of course, we are still getting some travel-related cases, but to date, we aren't seeing any ongoing spread outside of the particular unimmunized population. Next slide, please. And this is just to give that bit of a historical comparison. So this is only going back to 2013, but you can see obviously 2024, really large increase in cases. A big chunk of those were related to travel again. So that's the blue top of it, but that's the start of those outbreak cases. And then this year has been primarily driven by this single large outbreak. So, part of to share this to keep everyone up to date. And again, these are all posted online on PHO's website. And I think this, my weeks are right, then there should be another epi report coming out next week. But just to show that the increase in cases we're seeing are, again, very tied to specific unimmunized population. This is not a broad increase in risk across the province as a whole. And so certainly wouldn't be recommending people doing anything differently generally across the province. Really, it's a localized response if there's any change in our immunization recommendations. And anybody who's working locally in southwestern Ontario will probably be getting communications from those health units on what the response would be. So next slide. Okay, last one, just because we have the talk on HPV, I figured I'd do a quick thing on what we're seeing for HPV vaccine. As everybody knows, HPV immunization is part of our school-based immunization programs. So those 2 doses currently are administered in grade 7, and eligibility lasts through until essentially you're out of school and done high school. So next slide, please. HPV historically and for many years has not been among our best in terms of coverage, unfortunately. So this is our school-based vaccine coverage. So it's our Hep B, HPV, and meningococcal. You can see that the national targets are those purple lines up there, and we're unfortunately not meeting the national targets of any of them, but you can see that HPV is certainly among our lowest of any of them. So this has been a historical problem for quite a few years, and we haven't really seen an increase in HPV uptake, probably since the last 10 years, to be honest, like really since the introduction of the program. This is probably a little bit lower on this one just from last year's data, still need to get up to date. But, we've been hovering around 60% coverage for HPV for a very, very long time, and unfortunately haven't been able to get anything to increase. So if we can go to the next slide, I just wanted to compare to our provincial and territorial colleagues across the country. You can see Ontario is very, very near the bottom. So again, nowhere near our national targets. And so this is for females specifically. We have a couple provinces that are doing quite well. Newfoundland and PI have been excellent in hitting their targets. We've been very near the bottom for quite some time. And if you go to the next slide, This is similarly for boys. So, not, first of all, this is not every province and territory has the program in place. So we're just looking at boys for the places that have it. But again, Ontario near the bottom for our coverage, despite having that in place for quite a number of years. So this program in particular has been quite a struggle, and we see still a lot of hesitancy around HPV immunization, specifically different than what we see with some of our other programs. Next slide. So what I want to talk about now quickly is the update to the NACI recommendations that people probably saw. So this came out last year, but NACI made a few recommendations. Obviously, number one, continue to strongly recommend vaccination for everybody in the relevant age range. So 9 to 26 has been the NACI recommendation for some time. But the main change was recommending that rather than continuing with a 2-dose program, was that for individuals 9 to 20, we can move to a single-dose HPV program, with that older population, 21 to 26, still receiving the 2 doses. And so that is different than the current program in place that we have right now, which again, as I mentioned, is still a 2-dose program. And if we go to the next slide as well, the other thing NACI recommended was that for individuals 27 and older, basically those who are higher risk should also be considering getting a HPV vaccine as well. That would be a 2-dose schedule. But there's particular populations who are older that may still be at risk if they haven't received the vaccine to date. Ontario hasn't moved to make any of these recommendations as of yet. It's still under discussion and deliberation with our immunization advisory committee as exactly what would make the most sense in Ontario. But just to make sure everyone's aware of what the current NACI recommendations are, and this is something that we'll likely see in the near future in Ontario if there's any changes based on these recommendations. So that's it for me. Thanks, Eleanor.
Excellent. Thanks so much, Dan. And if we could just take the slides down, that would be great. Thank you. So a few questions have come up. We'll start with perhaps with the ones around measles. And so for Dan, do you think measles outbreaks are at a point where anyone who has an infant under age 1 should get an MMR if the family is traveling prior to age 1? And then obviously repeat after age 1.
Yeah, really good question. So I don't love recommending that dose because we do have very good data that giving that earlier dose under age of 1 does somewhat compromise longer term protection for those individuals. So we don't see that same boost from the following boosters as we would if we gave that dose over age 1, or even better over 15 months, to be honest, from what the data is showing. So if someone is high risk and traveling to a high risk area, so if you know that they'll be going to visit, family in an area where there's significant measles, that's a really good reason to immunize, of course, for that one. If we're talking about someone who's going to the Caribbean for a vacation, that's not something I'd be rushing to immunize a child early for that one. It's really about going to risky areas where there's likely significant contact with measles, as opposed to just any travel globally at this point in time.
Great, thanks, Dan. And then a question just around a reminder, what are the current recommendations for measles vaccines in adults and for travel?
Yeah, so similarly for adults, there aren't specific travel recommendations unless someone hasn't been immunized. They should still be getting up to date. Anybody born before 1970 is considered immune because prior to that time, we still had significant measles spread just within the community. If someone's born on or after 1970, then they'd be eligible for a single dose of measles vaccine. And if they're born later, then they'd be eligible for 2 doses. So 1996 is when we moved to the 2-dose program. So anybody born after that time is eligible for 2 doses. Of course, there's also high-risk groups that would be eligible, and high-risk, healthcare workers should all be getting 2 doses, that sort of thing. But generally speaking, for adults, most adults would be getting 1 dose in that age range. And then, at this point, I'm born in 1985, so everybody at that point should be getting 2 doses essentially for younger adults, let's say. I'll count myself in younger adults for a little bit still.
Thanks, Dan. Please do count yourself in that section. Otherwise, I'm not sure where I count myself. Actually, I think you've answered this other question, which is for an older patient in their 70s who hasn't been vaccinated and has no childhood history, should they get 2 MMR shots? I think the answer is no.
No, generally speaking, no, even if there's no specific history. Very particular cases with immunocompromise, it might still be worthwhile. But generally speaking, again, there was such community spread of measles prior to 1970 that we assume that there's been exposure.
And is there any risk in elderly patients that get the MMR? Any increased risk of the vaccine?
from receive the vaccine? No, again, it's the vaccine's very well tolerated. It's among our better vaccines. So if they are someone who should be getting it, it's reasonable to do so. But again, most who are in that age probably don't need it.
Great, thanks. We're going to turn over to a few questions around the flu. So, question, what is the status of bird flu, please? We have a surge in influenza A, and do we know the subtypes are not bird flu?
We do know that the subtypes are not bird flu. So it's a great question. So any hospitalized case has full subtyping done. At this point, we're about 2/3 of the cases, or no, it's getting a little bit closer. Most of the cases are still H1N1, about 2/3. The remaining are H3N2 for hospitalized ones. And then there's been a small number of influenza Bs. None of the hospitalized cases in Ontario to date have been H5N1. We subtype all of them, and we're confirmed on that one. For H5N1 globally, it's still increased from previous years. We are seeing a lot of transmission among both wild birds as well as domestic poultry. And so a lot of poultry in Canada has been found to be positive. There was only the one human case in Canada that was in that individual in BC, and we haven't seen any others. And we don't see any spread in dairy cattle in Canada as of yet. So, if we're talking about general population, the risk is exceedingly low for the general population of H5N1. The US is seeing more cases than we are, predominantly related to that increase in having dairy cattle as well. The one thing we can say is that most of the cases that are dairy cattle exposed have had very mild symptoms, conjunctivitis primarily, whereas the cases they've had that are directly related to avian contact have been a little bit more severe and requiring hospitalization. So certainly, yes, globally still an increase about previous, but nothing to the point where there's risk to the general population.
Great, thanks, Dan. That's reassuring to hear. Actually, just one further question, interesting thought. Should we be concerned that avian flu will impact the production of egg-based vaccines?
Yeah, that's a wonderful question. So one thing to point out is that most of the manufacturers are starting to move away from egg-based vaccines. That's just one among many reasons to do so. The manufacturing processes are a little bit better. At this point in time, it's a bit of a separate pipeline in terms of products. So it's not the same eggs you're buying in the grocery store that are going towards manufacturing vaccines. So to date, we haven't had any indication that there's any sort of issue with the egg supply to maintain our vaccine production. Again, I can never say concretely that will never happen. Certainly it could happen, but at this point there's no concerns.
Also good to hear. And I thought maybe we'll just turn over a question regarding rapid antigen tests. Where can the general public get them? And do we still need a positive rat to be able to get Paxlovid? And the attendee was just commenting how a patient had to buy one online for $10.
Ooh, $10 sounds like a lot.
Yeah.
So there are still rats available to healthcare providers. So it's primarily pharmacists and community primary care providers through the provincial antigen screening portal. If you're not on the portal, please get on the portal. You can still order for any patients who are eligible for treatment and provide it to them. That's still the best way. For anybody who's not eligible for treatment, there isn't a publicly funded available rat. So if it's someone who wouldn't otherwise be eligible for treatment, number one, we don't recommend testing because it doesn't really change management in someone who isn't going to be getting treatment specifically. But number two, the treatment is really the key part here. And the positive test is still required for treatment, yes.
Great, thanks. I think you answered one of the other questions that was further down the list.
Okay.
I wanted to turn things over to RSV, and I think we had a few questions about this last session too. So just when should we stop offering the RSV vaccine to older adults and Beyfortus to infants? And are we close to the end of the RSV season, which I think you did address, but yeah, if you could talk about how we manage the vaccines at this point.
For sure. Yeah. So we are getting close to the end of the season, as I showed. There will be an official announcement of the date of the end of the season to come. Probably that will come shortly because, again, as I showed, we're trending quite a bit out of the season. Once the season has ended, then we recommend stopping administration. So, for the older adults, the protection does last 2 or even 3 years for the product. So it's a little bit less urgent to stop immediately, but we do want to try to line that up with the seasons if we can. For infants, so that includes both the vaccine administered in pregnancy and the monoclonal, the protection only lasts 6 months. So if we're giving it, it will not last the next season. It will not be a benefit to give it after the end of this season. In terms of product that you have in your fridges, they shouldn't be expiring until well into next season. So please hang on to them, keep them in your fridges. Although, in some regions, public health may be available to help collect some of them if you have limited fridge space.
Great, thanks, Dan. And just a question, any word on whether the RSV vaccine coverage by the MOH might be expanded next fall?
It's a great question. And we saw obviously how significant it was for community dwelling older adults. That's under discussion as well to see. The NACI recommendations do suggest that everyone over 75 should be receiving the RSV vaccine. And so this is, in deliberation at this point to see if it's something we do in Ontario.
Excellent. A question just regarding the HPV vaccine. First, to clarify, at some point we used to do 3 vaccines, but you're saying now it's 1 for up until age 20. Is that correct? And then 2 if you're over that age?
So to be very clear, so those are the new NACI recommendations. Ontario has not yet moved to that updated NACI recommendations and are still following the 2 and 3 dose schedule for publicly funded. Of course, as healthcare providers, you can all look at the NACI recommendations and make recommendations to your patients based on what you think is the best evidence. But the official Ontario program is still the 2 and 3 dose program at this time.
Okay, good. That's good to clarify. Another question, is there any possibility that the province would be covering women in their 20s or older for funded HPV vaccine? Often we see young women, and I certainly see this in my practice, who parents opted out when they were in grade 7, but now they want to get it, but it's such a huge cost.
Yeah, again, great question. As I said, so all of those recommendations from NACI, including, everyone up to 26 are currently in discussion with our immunization committee for Ontario, and we'll see what recommendations come out and if there's any changes.
Excellent. Gonna give you one more question, and then I think we'll turn things over and come back to any further questions after we hear from the HPV folks. So this is a question regarding Prevnar and Pneumovax. Patient has had both Prevnar 13 and Pneumovax 23. Do they qualify for the publicly funded Prevnar 20? I believe the answer is no, but you can correct me if I'm wrong. And then let me just ask you the second part of the question, which is the patient has only had Pneumovax 23. Do they qualify for the Prevnar 20?
Yeah, so if they've had both products, then we do not have a catch-up in place to also add the Prevnar 20 on for individuals who had both products. So no, that person would be eligible. If they've only had part of the recommended product, so they haven't, officially completed the recommended schedule, then they would be eligible to essentially complete using the Prevnar 20 product. And it gets, it's somewhat complicated which products they've had and when and then what doses, so that we have I can't remember where it is now, but I'm sure we can post the link online, basically a table documenting exactly which doses they should be receiving based on whether they've had the Prevnar or Pneumovax, what they've had so far. But they would be eligible to complete, yes.
Great, thanks so much, Dan. And if you have the opportunity, there's a couple more questions in the Q&A, but we'll turn things over. But thanks very much for your update.
No problem.
Okay, so I'm going to turn things over now to Dr. Kupets and Susan, if we could bring the slides back up, that'd be terrific.
Okay, thank you, everybody. I think that now we're going to pivot a little bit and talk to you about our HPV-based cervical cancer screening program. Next slide, please. So after many years of planning and work, we finally launched our HPV-based cervical cancer screening program. It is now replacing the Pap test as the primary cervical screening test, and we went live on March the 3rd. So we were extremely happy that we made it to the finish line. And the reason that we switched over to HPV-based screening, as you know, is because HPV is a more sensitive test to pick up those individuals with cervical precancer. It will also help us find the glandular cervical cancers, the adenocarcinomas that Pap tests were having trouble finding. So we're very confident now that with this more sensitive cervical screening test, we will start to turn around the rise of invasive cervical cancer in this province. It is a test that, because it is so sensitive, it has a very high negative predictive value and a much longer protection. So somebody who's HPV negative can get retested in 5 years with reassurance that they will not develop cervical precancer or cancer in that 5-year interval. And so the test is safe, free, and only takes a few minutes. Next slide, please. This is the eligibility criteria. As you see, everybody who undergoes cervical cancer screening has to have a cervix. We changed our age of initiation to screening to age 25. This is in line with many other cervical screening jurisdictions and guidelines, and most individuals can stop screening at the age of 69. This screening test is for individuals who've ever been sexually active. They have to have an OHIP number to have access to screening within the OCSP. That doesn't exclude those people who don't have OHIP, but there are other streams to get them coverage. And as always, to remind you, cervical screening should be in asymptomatic individuals and not those that have a large cervical lesion or have very clear symptoms of cervical cancer. So these are the new features of the HPV test. Every HPV positive result will have 2 further triage strategies applied. First, there will be partial genotyping to let us know what HPV subtypes that patient is positive for. And because we're doing partial genotyping right now, it will be split out as HPV 16 or 18/45 or other. And everybody who is HPV positive will also have a reflex cytology done. And this will be happening automatically in the labs on the cervical screening specimen that you've provided. The reason that we do these substratifications is to let us the opportunity to estimate what the risk of cervical precancer is for that individual patient and to determine whether they need to go to colposcopy or whether they need to have their test repeated in a shorter interval. Next slide. So these are the changes now, comparing the cytology-based screening program that we've had for many years to the new HPV-based screening program. We switched over from cytology to HPV testing with reflex cytology. Our triage tests are the partial genotyping and the reflex cytology. We are now pivoting from screening average risk individuals every 3 years to every 5 years. And for the immunocompromised populations, and we do have a list of who qualifies as immunocompromised, we are now transitioning from yearly screening to screening every 3 years with HPV. For those individuals who may be at elevated risk, we are now moving from annual cytology screening to HPV testing every 2 years. As I've said, we've now moved from age 21 to age 25. And age of cessation is most individuals who've been of average risk during their screening history can stop screening between the ages of 65 to 69 with a single negative HPV test. Next slide, please. And so this is how to order an HPV test. It's fairly straightforward and intuitive. The first step is to confirm patient eligibility. So again, patient has to have a cervix, has to be 25 years of age or older, and has to have been sexually active in the past. The next step is to collect a sample from the cervix. And this is exactly the same way as you've done with patients for Pap tests. So only one sample needs to be collected, and the lab will automatically perform the appropriate tests. The next test is to complete the OCSP requisition and label the cervical sample adequately. And Jonathan will talk about these new requisitions. They are available online, and the labs should have distributed them to you, or they hopefully are in your EMR. And the last step is to submit the requisition and the sample to one of the procured lab service providers. Next slide. So this is how to collect a cervical sample. Again, it's very similar to what you're used to. You can use either the broom device right here on the right, or you can use an endocervical brush and spatula combination, We just want to make sure that we are sampling both the ecto and the endocervix. So either of these options will adequately sample the cervix. For lubrication, we recommend that lukewarm water is used. However, if a lubricant gel needs to be used, then we recommend a water-soluble and carbomer-free gel, and we can provide you with some names of what those lubricant gels are. It's important to apply the lubricant to the outer sides of the speculum blades and not in the inner part of the speculum that will come in contact with the cervix. Rotate the sample back and forth on the vial. We are now using thin prep as a liquid-based material. And this is a very important change from what we've had before for some of us who've been using liquid-based screening, is that no part of the collection device should be left in the vial when it goes to the lab. Otherwise, the lab will reject the specimen. So it's just important to swirl the broom or the spatula and endocervical brush in the liquid, and then remove it, and then close the vial, and label all samples with the patient's name and date of birth, along with the requisition, and send it to the lab. Next slide, please. This is the overview of what the screening algorithms are now, particularly in primary care and those care providers doing cervical cancer screening. It's important to ensure that the eligible population meets criteria. And then the sample is collected from the cervix. On the left side, if that patient is HPV negative, they are considered average risk, and they will have their next screen test done in 5 years, unless they're immunocompromised, in which case their next screen test will be in 3 years. On the right side, if the patient is HPV positive, the lab will perform reflex cytology on all positive HPV tests. And as I've mentioned, it will also divide out and provide us information on which HPV subtypes that patient is positive for. For those individuals who are 16 or 1845 positive, which accounts for 90% of cervical cancers, these patients are to be referred to colposcopy regardless of what the cytology result is. But it's important for us as colposcopists to know what the cytology test is, because it will help us manage patients appropriately within the colposcopy clinics. For those individuals who test positive for high-risk HPV, but what we call the other high-risk subtypes, those who have a high-grade cytology result will be referred to colposcopy. Those who have normal or low-grade cytology, which means LSIL or ASCUS, they do not meet that threshold risk for referral to colposcopy, because their risk of having cervical precancer is less than that 6% threshold. These individuals should have their cervical screen test repeated in primary care in 2 years. Those individuals who are still HPV positive, regardless of their HPV subtype or cytology result, should be referred to colposcopy, because they are now indicating that they have a persistent HPV infection, which is what is needed to develop cervical precancer. For those individuals who clear their HPV infection, and about 80% will do so within 2 to 3 years, these patients now become average risk, which is that green color, and they will go back to average risk screening every 5 years or every 3 if they're immunocompromised. Next slide. So this slide really talks about that right side algorithm of what to do with your positive HPV patients. Next slide. So once a patient enters colposcopy, they will undergo what is called an episode of care. And we have been very clear that there is a beginning, middle, and an end to the care that patients receive in colposcopy, and which is different than what's historically happened, where patients stay in colposcopy for a very long period of time with no benefit. So when that patient enters the colposcopy service, the colposcopist will determine what to do with that patient based on what that referral cytology is. And that referral cytology is the cytology that's diagnosed from that cervical screening specimen. For those patients who enter colposcopy with a low-grade cytology, and remember, they're all HPV positive, the colposcopist will evaluate that patient only one time. They will not be repeating the HPV or cytology test because it's not required. If we have ruled out a high-grade cytology, which is really the purpose of colposcopy, to identify high-grade cytology, that patient will be discharged back to you in primary care. And it's very important for the colposcopist to provide recommendations to primary care physicians as to when that next screen test should be done. Typically for these patients, because they are entering and are HPV positive, and they don't have a high-grade dysplasia, but they've demonstrated HPV positivity, the recommendation will be for primary care physicians and care providers to repeat that HPV test in 2 years. For individuals who enter colposcopy with a high-grade cytology on referral, at initial colposcopy again, if a high-grade dysplasia is identified and confirmed on biopsy, which is the middle part in red, that patient will be treated in colposcopy to have their high-grade dysplasia removed, and they will be kept in colposcopy for at least 2 visits to ensure that the lesion has been treated adequately before we send that patient back to you in primary care. And we will also be providing recommendations as to when that next screen test needs to be done in primary care. Some of these patients will need to have their test repeated in 2 years, and the majority will be able to have their screen test repeated in 5 years. So again, it's really working with the colposcopist to know when that screen test should be in primary care. Is it at 2 years or is it at 5? Now, some patients referred to colposcopy with high-grade cytology will not have an actual high-grade lesion identified because a screen test is not a diagnostic test, of course, and anywhere from 30 to 70% of people referred to colposcopy will actually not have a high-grade lesion. For those patients, we will see them back in 12 months for a second colposcopy test, and we will be doing an HPV and cytology, which is a co-test in colposcopy. If at that second visit, we find a high-grade lesion, those patients, again, will be treated. But if we do not find a high-grade lesion after 2 colposcopies, those patients will be discharged back to you in primary care, again, with recommendations as to when to do the next screen test, at 2 years or at 5. Next slide. And so we get this question a lot because now we're in a transition phase from cytology to HPV testing. So we almost have to merge both of our cytology-based guidelines and the new HPV guidelines to know what to do for patients who've had cytology-based screening. So for those individuals who are average risk because their cytology is normal, or they've returned to average risk screening after a low-grade cytology result, so if they've had an L-cell pap followed by 2 normal paps, they are now at average risk. And remember, in the cytology-based world, average risk patients screen every 3 years unless they're immunocompromised. So if your patient has had a normal cytology test, their next screen test should be in 3 years with an HPV result, and then you can determine what to do based on that HPV test. They may be able to go to every 5 years, or if you find they're HPV positive, you have to follow the algorithms. For an immunocompromised individual, if they've had a normal pap test in a year, their next test will be in 12 months after the first pap test with HPV. For those patients of yours who've had an ASCUS or L-cell cytology result, or ASCUS L-cell cytology followed by normal cytology, these are what we call moderate risk. So that's the, I think that's the yellow color in our new risk-based algorithms. These individuals should be rescreened in 1 year with HPV. And then you can follow the guidelines based on their HPV result. And those patients who've been discharged from colposcopy back to you with recommendations that they should have annual screening, they should be tested as per guidelines in a year with HPV. And then you can follow the guidelines for HPV. And those patients who are discharged from colposcopy who have returned to average risk screening, they can be rescreened in 3 years. And then you can follow the guidelines again, and of course, make adjustments for their immunocompetent status. For patients who have histologic evidence of cervical dysplasia at the time of their hysterectomy, so this is for vault screening, we recommend 1 vault test be done after that hysterectomy in 6 to 12 months after their uterus and cervix has been removed. And really, we want to ensure that no dysplasia was left behind at the top of the vagina at the time of their hysterectomy. For those patients who have 2 negative cytologies at their vault or 1 negative HPV test, they do not need any more vaginal vault testing. And even though we are a cervical cancer screening program, we did want to incorporate vault testing because we know that many times patients are overscreened who've had a hysterectomy and just have a vaginal vault. We wanted to provide some evidence-based guidelines as to what to do with those patients after hysterectomy. So the majority do not need vaginal vault testing. Only those who have cervical dysplasia or an early cervical cancer in their cervical specimen at pathology should have vaginal vault testing. Next slide. So this is our risk-based screening categories. We wanted to transition from cytology-based screening to risk-based screening so that we have equal management for equal risk. The average risk patients are to be screened every 5 years. Unless they're immunocompromised, they're screened every 3. The moderate risk patients are those that have an HPV infection, which are typically HPV other, with normal or low-grade cytology. They do have some risk of having a cervical precancer, but their risk is not high enough to get them into colposcopy, so they will be rescreened in 2 years. And then we have those patients who are at elevated risk, whose immediate risk is 6% or higher of having cervical precancer, which is HSIL or SIN3+, and they need to be referred to colposcopy. Next slide. So I'm going to hand this over to Jonathan now so he can take us through the requisition changes.
Thanks, Rachel. So post HPV launch, you'll be required to fill out this new OCSB specific HPV cervical screening requisition form. You won't be able to use the older Ministry of Health laboratory requisition or hospital requisition that were used for the PAPs. This requisition will be, Ontario Health has been working with the EMR vendors to make it available on your EMRs. You can Google HPV Hub or go to ontariohealth.ca HPV Hub to access this requisition if you need to. If you order materials from labs, they'll be sending you even a paper copy of this requisition. Next slide, please. And we're just going to zoom into the top part of the requisition that basically shows you the eligibility criteria that Rachel already outlined for you. It also lists the immunocompromised populations that are included, and that includes people living with HIV/AIDS, regardless of CD4 cell count, people with congenital immunodeficiency, people with lupus, regardless of whether they're receiving immunosuppressant treatment, people with renal failure and require dialysis, transplant recipients, as well as people requiring treatment continuously or at frequent intervals with medications that cause immune suppression for 3 years or more. People who are not included in this population would be anyone who's people with Crohn's disease or multiple sclerosis who are not receiving any immunosuppressant treatments. People with diabetes are not included in this population, as well as any person with a past history of cytotoxic treatments for cancer. For example, a person who's treated for breast cancer with chemotherapy for, and are in remission of, they would not be considered immunocompromised. Next slide, please. And the bottom half of the requisition includes the testing indication for cervical screening, which you'll be required to fill out when you complete this form. And this is useful because when you input the right information on the indication, we can then tell you accurately what the next steps are when the results come in, and that will be helpful to you. And so those test indications would be for your average risk screening, people who are defined as immunocompromised. Rachel talked about when someone has a result that's HIV positive other and they need to stay in primary care and they need a repeat test at 2 years, that would be that third box. Anyone who's discharged post-colposcopy, when you receive that discharge summary, the colposcopist may tell you to do a repeat test at 2 years, you'd be clicking that box. And then finally, Rachel also mentioned the vaginal vault testing for people who've had a hysterectomy and there's a histologic evidence of dysplasia in the cervix at the time of hysterectomy, or if they had a history of early cervical cancer, a one-time post-hysterectomy vaginal vault test would be indicated. And then under B, if you ever order an HEV test where it returns as HEV positive, but there's an unsatisfactory cytology result, and if you have to retrieve another sample, you'd be clicking this box to just retrieve a cytology only. That would be the only context you'd fill this box. If you're ever ordering the HEV test, you'd be using the one of the items from category A. Next slide, please. So reasons why requisition could be rejected. If you fill out the rec and the patient's not eligible for cervical screening due to they don't meet the age interval. If the requisition itself is incomplete or illegible. If there's a missing cervical sample, that could also lead to a rejection. And more importantly, if you leave any parts of the cervical sample, including the broom head inside the vial itself, that will surely lead to a rejection. Duplicate requisitions. If you fill out cytology only requests, and there hasn't been a previous HV positive invalid cytology, that could result in a rejection. If you check off multiple indications, that could result in a rejection. And finally, if there's a missing testing indication. Now, the labs may recognize these discrepancies and they may attempt to contact the requester at least 3 times to get the correct information. But if they cannot get that accurate information, then the requisition would be rejected. And if for any reasons there's a requisition without a sample to say, and the sample's in your fridge, there is a slight window that it's okay, you could still provide the sample back to the lab if it's been in your fridge for a few days, you could forward it along. Next slide, please. So this is just, again, I'll call it to the HEV testing resource hub that has all the resources available to primary care. It includes a guide to cervical screening. It includes a guide to resuming screening post-discharge from colposcopy, a guide on how to collect a cervical sample, the screening requisition and instructions, FAQs, etc. There's the link is on the right. You can also just Google HEV Hub and it will return, it'll be one of the first few hits. Next slide. I believe that, and this is the final slide, I believe. Sorry, thank you. And we'll take questions from this point on.
Great, thanks very much, Jonathan and Rachel, and maybe we can just take the slides down. So yeah, lots of questions, some of which have already been answered. So if people are actually looking or are watching, then they can go to the answered questions, but I'll go over some of them again, because I think for those of you that are just listening, it might be important to hear the answers. I thought I would just start a couple of just system questions. So first of all, just the first question up there is how much less accurate, and I think this speaks to the question of self-swabbing, but let's start with the clinical side of it. How much less accurate is the self-swab for HPV testing versus the swabs that we do in the office?
So I can start by answering that. You can hear me, right? Yes. So we have not rolled out with HPV self-testing broadly in the province because we have to learn more about how the test works and how accurate it is. And by that, I mean, what is its sensitivity? What is its positive predictive value and its negative predictive value? So there is a pilot project going on in some select clinics in Ontario so that we can find more information out on patient preferences, how well the test works, that workflow that arises from a self-test. There is only one self-test HPV kit that is approved by Health Canada, and that is it's a DNA-based test, which is PCR. Right now, we are rolling out with RNA testing for OCSP, which is physician collected. Based on some literature, there is a suggestion that self-testing is almost as sensitive as a physician collected test. However, that's based on a lot of retrospective data. And so there are a lot of validation, there's a lot of validation research ongoing. So once we have a better idea of how HPV self-testing works, I think a lot of jurisdictions that are incorporating it, including ASCCP, suggest that somebody who's negative on self-testing should be rescreened in 3 years rather than in 5 if they're HPV negative when it's physician collected versus self-collected. So there's more to come on that, but there's still a lot of information that we need on self-testing. Jonathan, did you have anything to? Okay.
Yeah, I think I guess the other question that's come up along those lines is just because I think, I guess in BC, there is self-screening. So a comment from from one of the attendees, like as a male physician, I have many female patients who are not comfortable seeing me for a speculum exam and are not getting screened. So see self-screening as an important way to get the most high-risk women screened. Just wondering if you can comment on, how it's happening there.
So we did speak to BC, and we spoke to a lot of other jurisdictions in Europe that do have the component of self-sampling. They've seen a small rise in uptake, especially in equity deserving groups and people that don't want their physician to do the test. But in BC, what they've noted is a very large proportion, I think 40 or 50%, still want the physician to collect the sample. The other thing is that somebody who's HPV positive on self-sampling, they will still need to have the physician collect a test from the cervix so that we know what that cytology result is, so we know how to manage them in colposcopy, or whether they need to wait 2 years to see if their HPV infection clears. So HPV self-sampling can help in some populations. It's a small benefit. It's definitely something that we're very interested in OCSP, but it doesn't preclude a physician having to examine the HPV positive patients. But I do agree that that will be a small proportion of patients who will need that physician collected sample, and the majority will be HPV negative. So more to come on that.
Thanks, Rachel. Just another question. Jane commented the CBC reported that in BC, the higher number of results with HPV positive tests has flooded the need for colposcopy, and they've had actually a huge backlog. She commented in Niagara, it's already impossible to get patients in to see gynecologists, and just wondering how that might be managed in Ontario.
So we're very aware that the number of HPV tests that will come back positive is going to be a lot higher than Pap tests coming back that are abnormal. In particular, about 6% of cytology tests are abnormal, and probably double will be HPV positive. And this is why we've instituted a triage test to help navigate those patients who don't need colposcopy, who likely just have a transient HPV infection. We do know that colposcopy referral rates will go up, but it's very important as primary care physicians not to refer patients that don't meet criteria for colposcopy. Hopefully on our side in colposcopy, we'll be triaging those referrals and declining them if they don't need to be seen in colposcopy. We did note that with changing the age of screening to age 25, hopefully we won't see as much of a bump in colposcopy, and also our participation rates. That's not a good news story, but our participation rates have gone down a fair bit, so we may not be seeing as much of a bump of referral to colposcopy, but obviously we want participation rates to be very high. Right now, since COVID, they've drifted down, and that needs to be repaired. but we will adjust as needed. And now we've also encouraged colposcopists to discharge patients that have been in colposcopy forever and don't need to be there. So hopefully by making these adjustments and using triage strategies, we won't have as much of a load, but we'll see. We'll continue to monitor.
Great, thanks. And it's good to hear that obviously you've been anticipating that this could be an issue and putting things in place to help with it. I'm going to ask you one more question before we just turn to our final few slides to make sure that we're finished by 9. But I'm just going to ask you this one question in case there are people that need to sign off right at 9. Because I think there were a few questions around this, and you did answer it in your presentation, but I think just wanted to clarify it. So it's regarding those patients that have had ASCUS or LSIL follow-up. So this is the question. I understand the new HPV screening algorithm, but what do we do with the follow-up for the non-colposcopy ASCUS and LSIL cytology follow-ups from last year that we were supposed to repeat in 1 year? The person asked, do I ignore the previous ASCUS or LSIL results from 2024 and just do the new HPV testing?
Jonathan, did you want to address that?
Well, I was just going to say when they would have been next due for their PAP would be the timing that you would perform the HPV test. And the pre-existing screening modalities that were employed, they were good enough to reassure that it was safe to wait to screen to that next interval. So you can comfortably, if they had asked us and they're due for another test in 1 year, at that 1 year mark, you'll just, instead of finding that ministry rec, you're going to find the OCSB rec and do an HPV test.
Thank you both. Before I turn things over to Jobin, I just wanted to point out there were a couple of questions around accessing PAPs for those that are not OHIP covered or under IFH. And I did notice there was a comment in the chat about how you can order on the how you can order for IFH patients. So please check out the chat regarding that. And then we'll come back to you, Rachel and Jonathan and Dan, in just a second. I'm just going to turn things over and bring up the slides again. Turn things over to Jobin for a moment.
Thanks. And I won't take too long, but I wanted to point out a couple of things. We have our small group learning sessions that we have on here, and the deadline to register is March 12th. So I welcome everybody to consider doing that, especially with those that are related to mental health, substance abuse, chronic pain, and your own wellness. Next slide. We also want to make sure that people are aware of the OCFP awards. The deadline is very rapidly approaching of March 16th, next Sunday. There are 4 awards, and we recommend or we ask people to consider doing that. We've put it in the chat. We'll make sure it's in the after information as well. Next slide. And then our osteoporosis and fracture prevention workshop continues to be a big hit. We have another one set up for March 19th. Consider taking on this workshop if you haven't yet done it. It's a really good one. Next slide. And a reminder about the mental health, addiction, chronic pain communities of practice that we have. They're up on the slides here, including our peer Connect mentorship. So all of which are incredibly helpful, and we want to continue to provide as many resources as we can to our family physicians. If there's some that you want to let us know about, feel free to reach out to us. I think I'm turning it back to you.
Great, thanks very much, Jobin. So this actually is applicable to Toronto-based physicians, but we put it up here because it's going to be hopefully applicable to all provincial physicians in the future. So we are conducting a primary care census in Toronto, and the idea is actually really to find out who's practicing and where they're practicing so that we can support ongoing efforts in human health resource planning. And also support regional initiatives. And we're rolling it out here in Toronto, but also then hoping that this will be like a pilot for us rolling it out more provincially so that we can make sure that we get the supports that we need as primary care physicians. So next slide. I would just ask those that are Toronto-based, if you haven't already filled out the census, if you can just scan this QR code and fill it out when you have a moment. It does not take that long, maybe max of 10 minutes. And next slide, please. Just a reminder, we've had some really great sessions recently that you can always check out, particularly if you wanted more information on bird flu, check out our last one. Next slide, please. And some upcoming dates, on March 21st is the next one in a couple of weeks' time. Next slide, please. And then, of course, a reminder that you can always look at our slides and get all our resources afterwards, and our next community practice is in 2 weeks' time. Next slide, please. I think that's the last slide. For those of you that do have to sign off, if you are people with children and are about to go on March break, I hope you have some time off and get to enjoy some time with family. For the rest of you, I hope you have a wonderful weekend, and then we'll just turn back to those that are able to stay for a few additional questions. We'll take the slides down and perhaps bring back our panelists. Great. So I wanted to actually just go back to a question for Rachel and Jonathan around something that many of us do encounter in practice, which is where patients actually really want to get the test done more often than is recommended, and actually, you know, say, well, I'll pay for it. So I'm wondering if you could address that. First of all, just, you know, if you have some good education around how to speak with these patients, and also if they do choose to do private pay, you know, how that process works.
I can start, and then maybe Jonathan can jump in. So the purpose of HPV testing for cervical cancer screening is very clear. We're looking for people who have cervical precancer, and it's really important to understand the natural history of HPV infections. The majority will come and go and not cause any problems on the cervix. So really, we're doing it to find people who are at risk. So about 80% of patients will clear their HPV infection in 2 to 3 years. And there are no long-term sequelae with that regard. It's also important to know that the natural history of cervical cancer is very long. So the peak time of transmission of HPV are in individuals in late teens, early 20s. The cervical precancers, and I don't mean LSIL, I mean HSIL, SIN3, happen to individuals in their late 20s to mid 30s. And then about 25% of untreated cervical precancers will develop into invasive cervical cancer. And again, that takes a very long time because the peak age of cervical cancer that's invasive is bimodal. It's in ages mid 40s to mid 50s. So that's why cervical cancer screening works so well, is because you have many, many, many opportunities over a long period of time to find those individuals who have a lesion that needs to be treated in colposcopy. We don't treat low-grade dysplasia. In fact, if we find somebody who has an LSIL on biopsy, we don't treat them. We just wait for that infection to go away because these lesions don't really progress into cancer. So it's important to explain to your patient why we're doing cervical screening. It is not an STI check. It is really a check to see who's at elevated risk for cervical cancer, and those patients need to be treated. If patients start to self-pay and start to see if they're HPV positive for different reasons, they run the risk of being overmanaged, and overmanagement causes harm. And so we were very clear right now, because our threshold risk for referral to colposcopy is about 6%. We're doing about 20 colposcopies unnecessarily to find that one patient with cervical precancer. We don't want to start putting 50 patients unnecessarily through interventions that may cause infection, bleeding, preterm deliveries, etc. And so we don't want to overmanage patients, because more testing, as we know, does not mean better outcomes or better health. And I think we know that when it comes to imaging, when it comes to everything else that we do. So it's important to educate our patients to say that HPV testing is not meant for STI testing, and that they run the risk of finding incidental new transient infections that have absolutely no impact on their well-being. And also, a negative HPV test has at least a 5-year protection of almost 100%, 99.7%, that patient will not develop cervical precancer on their cervix at that 5-year interval. And if they're vaccinated and they're HPV negative, that window of protection is even longer. So hopefully some of what I said helps.
Yeah.
Jonathan,
Thanks, Rachel.
did you want to add anything?
Just if people private pay and they return positive, then the patient will end up being redirected to primary care, who will then have to navigate the referral to colposcopy. And if it's a HPV test that doesn't include a cytology, then the provider is going to have to be performing a cytology themselves in conjunction with the HPV, so that they're eligible for referral to colposcopy. So it just adds an extra layer of complexity and workload for you into the whole system. So I think Rachel gave a fulsome answer there that you could hopefully use to help educate patients.
Yeah, thanks, Rachel. And Jonathan, I think helpful just to hear also as a reminder that many of these infections just come and then go. So that's useful information as well. Quick question, is there any wiggle room on the screening interval? For example, currently you have about 3 months, like you can order it at like 3 years minus 3 months. Is there similar wiggle room with the new test?
Go ahead, Rachel. I believe there is another 3 month. There is a next, as it applies to the fit testing, you have the same wiggle room, the same way. Yes.
Yeah, well, we know patients aren't going to come in exactly at the 5-year mark. You don't want to turn them away. So I do think that there are adjustments in the fee schedule, and maybe Riley can add to that in the chat. But I know that we did talk to ministry about that window.
Thank you. A question in terms of why we stop at age 70 or 69. Is there a reason that we don't keep going after that point? Especially if somebody at age 70 had a new partner? Not sure if Rachel or Jonathan, if you have any thoughts around that. Looks like Rachel might have frozen, actually.
Oh, she froze. My understanding with cessation criteria is that basically at a certain age, first of all, a negative HPV test is highly protective for someone in their 60s. It gives a 5-year window of protection that once you have that negative test, that reassures that like we don't have to screen any further. But Rachel, if you wanted to add further about if someone has a new partner in their 70s, should they be screened for HPV?
Sorry, I froze. So the question is,
the question was about testing, like why stop at age 70, essentially, especially if someone had a new partner when they were older.
So as I said, you need about 20 to 25 years of a chronic HPV infection to develop cervical cancer. We know that the average life expectancy in Ontario or maybe Canada is 80, 81, 82, something like this. And so for that reason, we did recommend for patients to stop screening if their average risk at age 69. For those patients who are HPV positive in that 65 to 69 window, they should navigate the pathways as I've laid out. And after 74, there should not be any screening at all. So somebody who's been of average risk and now has a new partner, their chance of developing cervical cancer is very low, and it will take 20 years. So they don't need the HPV vaccine and they don't need to be screened.
Great, thanks very much. A question about if a non-immunocompromised eligible patient had a PAP 1 year ago, when should they have their HPV screening test in 2 or 4 years? Actually, I'm just reading that through. Maybe I'll ask that person to just pose that question again, because I'm not sure I understand it when I'm reading through it there.
If they had a PAP, their next screen test should be in 3 years from that PAP date, because they're average risk. So if they
Excellent.
Yeah,
so they just basically, if someone should come in around their regular time for when they're due for their PAP, there's no need for people to come in early.
No, please don't do that.
Yeah, I think also I was just going to mention there had been a few comments in the chat around lubricants. And I would say that I had looked on the hub that you guys have provided, and there is an excellent list of lubricants because I think this test is quite a bit more sensitive to having a lubricant present. Is that the case, Rachel?
I think that for cytology interpretation, we've always recommended not using a lot of lubricant or something that's going to get in the way of that cytologist seeing what the cells look like. And so I think it's just important to follow the manufacturer's guidelines to make sure that we don't get tests that are not interpretable.
The carbomers could compromise the results and interfere with the filters and create invalid results. So that's why it's a list of carbomer-free water-soluble lubricant.
Great. A question, if the the cervical os is stenotic, is the HPV testing still accurate?
Well, we have to work with what we've got. So if you get a satisfactory result, if you get a valid result, then we would be, going based off of that result. If the result is invalid or the cytology is unsatisfactory, and the pathologist states that they can't really do a good exam, there are some guidelines as to what to do if somebody has 2 unsatisfactory exams, cytologies, or 2, I think, invalid, then they should go to colposcopy, just for us to take a look at the cervix. I don't know that we'll get any further ahead because it's very hard to evaluate a stenotic cervix, but we have to deal with, the clinical situation at hand.
Great, thanks, Rachel. And I think we'll finish off with 2 questions just around vaginal vault. So first of all, do you have to use a special brush or broom or the wooden spatula for a vaginal vault test, or is it fine to use the regular broom?
So Jonathan's nodding. So I think, yeah, go ahead.
Yeah, so it's fine to use I believe the regular broom is fine to use to collect the sample.
Yeah. And I just want to say, please do not overscreen your patients with vaginal vaults. We see so many patients who've had annual PAPs for many, many, many years. I think, we ran our own Ontario data. Vaginal cancer is extremely rare. It does not qualify for a screening program because it's less than 4 per 100,000. And it's really those individuals who have evidence of cervical dysplasia. You want to make sure that at hysterectomy, we removed all of it and we didn't have positive margins. And so 1 HPV test or 2 normal pap tests, no more vaginal vault testing.
Which is also why we put on the requisition the very specific indication for the vaginal vault testing and specifying that it actually is a one-time test only, one and done.
Great, thanks very much. I mean, I think that answered another question that was there about a patient that had a hysterectomy for adenocarcinoma. So that is a change for us. So that'll be a few less PAPs or a few less HPV tests to do for those that were getting them in their vaginal vaults. So only 1 is required. I think we'll finish there. There are a few more questions, but many have been answered. We will be obviously collating our questions and sending them around with our resource list, which everybody receives after attending the session. I really thank the both of you as well as Dan for your presentations, for bringing us up to speed on everything infectious disease wise and HPV screening wise. And thanks again for joining us today. Take care, everybody. Have a great weekend.